हमें लगता है कि इतने सारे सब्जेक्ट्स हैं 1.5 मंथ्स में कैसे होएगा, बट 1.5 मंथ्स कम नहीं होते। कुछ दिन कम पढ़ पाओगे, कुछ दिन ज़्यादा पढ़ पाओगे, बट जस्ट मेक श्योर कि डेली पढ़ेंगे। टेस्ट एंड डिस्कशन सारे प्लेटफॉर्म्स पर ऑनलाइन फ्री में अवेलेबल हो चुका है। अब आपने 19 में से 10 to 12 सब्जेक्ट्स बहुत स्ट्रॉन्ग कर लिए, स्पेशली जो इंपॉर्टेंट है। I can guarantee you you'll get selected in NEET PG and get the branch of your choice. These subjects are important. अगर इनमें से आपके कोई सब्जेक्ट्स वीक हैं, स्पेशली अगर आपके फर्स्ट सेकेंड ईयर सब्जेक्ट्स वीक हैं, तो उनको अभी इन 35 डेज में कंप्लीट कर लो। हेलो स्टूडेंट्स, सो वेलकम टू टुडेज टेस्ट एंड डिस्कशन ऑफ रेडियोलॉजी एंड आई होप योर एग्जाम क्वेश्चन टेस्ट वेंट वेल एंड जस्ट पुट इन द कमेंट सेक्शन कि हाउ वाज द टेस्ट। नाउ INICET इज जस्ट राउंड द कॉर्नर, 19th में बस आ ही गया है एंड नीट PG ही है हमारा मेन एग्ज़ाम, वही है हमारा मेन टारगेट, उसी में सबसे ज़्यादा सीट्स हैं और उसी के लिए हम तैयारियां कर रहे हैं। तो नीट PG में अभी है टाइम, 23 जून को है, हाँ, एंड 1.5 मंथ्स हैं। एंड भाई अगर अभी भी डट के स्टार्ट नहीं किए ना तैयारी, तो कर लो, अभी भी हो जाएगा। मुझे अभी अभी मैसेज आया इंस्टाग्राम पर एक स्टूडेंट का कि सर माई मदर पास्ड अवे ड्यू टू कैंसर and since the last 2 months I have not been able to study at all and अभी 1.5 months बचे हैं एग्जाम के लिए. Do I still have a chance to crack this NEET? And I told her very seriously that 110% you have every chance to crack NEET PG because 1.5 months कम नहीं होते. पता है, हमें लगता है कि इतने सारे सब्जेक्ट्स हैं 1.5 मंथ्स में कैसे होएगा, बट 1.5 मंथ्स कम नहीं होते. अभी भी स्टार्ट कर लो, एक प्रॉपर स्ट्रैटेजी के साथ स्टार्ट करना. हाय, गुड इवनिंग नेहा, हाउ आर यू? तो आई वाज सेइंग कि अभी भी 1.5 मंथ हैं, अभी भी कर लोगे स्टार्ट तो अभी भी हो जाएगा. बस मेक श्योर कि आज से मैं कर लूँगा, अपना पास्ट भूल जाओ. पता है, मैं अपने जूनियर से बात कर रहा था, आर्यन, एंड ही सेड कि मैंने अपना प्रिपरेशन में ना 1 हफ्ता पूरा वेस्ट कर दिया टूवर्ड्स द एंड ऑफ माई प्रिपरेशन. लाइक 1 महीना बचा था, 1 हफ्ता पूरा वेस्ट कर दिया. एंड वो उसको अभी तक इतना चुभता था ना कि यार उस टाइम पे मैं पढ़ लेता तो 100 रैंक और जंप हो जाती. तो इस टाइम पे बस एक रूल फॉलो करना, बस एक रूल, कि डेली पढ़ना है. ठीक है, कुछ दिन कम पढ़ पाओगे, कुछ दिन ज़्यादा पढ़ पाओगे, बट जस्ट मेक श्योर कि डेली पढ़ेंगे, डेली पढ़ना है. ठीक है, दिस इज आवर टारगेट. So we'll wait for some time. Let some other people join as well, and then we'll start test and discussion. Right? Just put in the comment section how was the test. I'll keep looking here for a while because the comment sections are here. So I'll get a feedback what all you people are commenting, and we'll start the test and discussion now. Okay, so we'll start with test and discussion now. And उससे पहले ना, let me just give you a whole planning of how you should prepare for your NEET PG now. हम NEET PG के बारे में बात करेंगे. So today is 4th May, right? And हमारा एग्जाम is on 23rd June. तो है हमारे पास अराउंड 1.5 months. ठीक है, सो इन 1.5 मंथ्स में कैसे तैयारी करनी है, हम अभी 10 मिनट में, शुरुआत के 10 मिनट में विल स्टडी अबाउट दैट. तो मेरा क्या स्ट्रैटेजी रहता है, अगर 1.5 मंथ्स को हम बोलें 45 डेज, तो जब भी मैं किसी भी एंट्रेंस एग्जाम के लिए तैयारी करता हूँ, एंड इट डिपेंड्स कौन से एंट्रेंस एग्जाम है, उसके थोड़ी स्ट्रैटेजी थोड़ी डिफरेंट होती है. बट नीट PG के बारे में इफ यू टॉक अबाउट, सो 45 डेज माइनस 10 डेज करो आप, बिकॉज लास्ट 10 डेज में हमें पूरा रिविजन दोबारा करना है. दिस इज माई पर्सनल स्ट्रैटेजी. इफ सम ऑफ यू फॉलो मी ऑन यूट्यूब, दिस इज समथिंग दैट आई ऑल्सो टॉक अबाउट द लास्ट 10 डे रिविजन. ठीक है, तो लास्ट 10 डेज को हम अलग कर देंगे. अब हमारे पास टारगेट है कि 35 डेज है हमारे पास. 35 डेज में हमें सब करना है जो हमारा बचा हुआ है. तो 35 डेज को हम कैसे प्लान करेंगे? 35 डेज में हम पहले तो ये लिखेंगे कि हमारे वीक सब्जेक्ट्स क्या हैं, वीक सब्जेक्ट्स क्या हैं. दूसरा हम लिखेंगे कि इंपॉर्टेंट सब्जेक्ट्स क्या हैं, इंपॉर्टेंट सब्जेक्ट्स क्या हैं. ठीक है, हो सकता है कि जो हमारे वीक सब्जेक्ट्स हो वो इतने इंपॉर्टेंट ही ना हो, तो इतना फर्क नहीं पड़ता हमें. अब इंपॉर्टेंट सब्जेक्ट्स कैसे चलेगा पता, देखो नीट PG में इंपॉर्टेंट सब्जेक्ट्स INICET से ऑलमोस्ट सब सिमिलर ही हो गए हैं. ठीक है, सो फर्स्ट सेकेंड ईयर वेरी वेरी इंपॉर्टेंट. सर्जरी, ऑब्स, गाइनी, मेडिसिन भी थोड़ा नीट PG में ज़्यादा इंपॉर्टेंट है. बट अगेन, अगर आपको टॉप 1000 रैंक चाहिए ना, देन मेडिसिन सर्जरी से फ़र्क नहीं पड़ता. तो इंपॉर्टेंट सब्जेक्ट्स मेरे हिसाब से किसी भी एंट्रेंस एग्जाम के लिए, स्पेशली नीट पीजी वाले जो हैं, उसमें फर्स्ट सेकेंड ईयर, ऑब्स गाइनी, फोरेंसिक, सर्जरी एंड माइनर्स में आई थिंक ऑर्थो एंड साइकेट्री। दीज सब्जेक्ट्स आर इंपॉर्टेंट। अगर इनमें से आपके कोई सब्जेक्ट्स वीक हैं, स्पेशली अगर आपके फर्स्ट सेकेंड ईयर सब्जेक्ट्स वीक हैं, तो उनको अभी इन 35 डेज में कंप्लीट कर लो। ठीक है, कैसे कंप्लीट करोगे? व्हाट आई वुड सजेस्ट कि जो जो वीक सब्जेक्ट्स हैं उनका आप अभी टेस्ट एंड डिस्कशन लगा लो। टेस्ट एंड डिस्कशन सारे प्लेटफॉर्म्स पर ऑनलाइन फ्री में अवेलेबल हो चुका है। अब अगर कहीं नहीं हो रहा तो पीडब्ल्यू की साइट पर है सारे टेस्ट एंड डिस्कशन फ्री। ठीक है, तो आप क्या करो कि जो जो वीक सब्जेक्ट्स हैं उनका 3 to 4 डेज का टारगेट बना लो अगर वो मेजर सब्जेक्ट्स हैं, और 1 to 2 डेज का टारगेट बना लो अगर वो माइनर सब्जेक्ट्स हैं। तो इन 3 to 4 डेज या 1 to 2 डेज में व्हाट आई विल डू, मैं रिवीजन नोट्स उठाऊंगा उस सब्जेक्ट के। आई विल डू प्रीवियस ईयर क्वेश्चंस ऑफ दैट सब्जेक्ट एंड देन आई विल डू अ टेस्ट एंड डिस्कशन ऑफ दैट सब्जेक्ट। So for weak subject, what will I do? I'll do revision videos, revision notes. I'll do previous year questions, and finally I'll do a test and discussion. That's about it. ये तीन चीज अगर मेरी हो गई for weak subjects, I will not see main notes for these weak subjects now. I will not see any other source. These three things will suffice my weak subjects revision now. ठीक है, दिस इज आवर स्ट्रैटेजी फॉर ऑल द वीक सब्जेक्ट्स। अगर इन 35 डेज में आपने 19 में से 10 to 12 सब्जेक्ट्स बहुत स्ट्रॉन्ग कर लिए, स्पेशली जो इंपॉर्टेंट है, आई कैन गारंटी यू विल गेट सिलेक्टेड इन नीट पीजी एंड गेट द ब्रांच ऑफ योर चॉइस। ठीक है, दिस इज माई गारंटी। इन 35 डेज के बाद लास्ट 10 डेज में बस थ्योरी पढ़ना है, बस थ्योरी पढ़ना है, बस थ्योरी पढ़ना है। ठीक है, ये स्ट्रैटेजी फॉलो करो एंड आई एम श्योर अभी भी 1.5 months बचे हुए हैं, अभी भी you can get a good rank in NEET PG. Now with that we'll start today's class and we'll start with the various questions. Now the topics that we'll cover in today's class are basically systemic radiology and also touch upon nuclear medicine and radiotherapy. So the first question is a 52 years old patient presented with complaints of frontal headache. An X-ray is shown in the image below. What is the most likely diagnosis? So what have you guys marked? Tell me the answer. Tell me what you all have marked. Okay, so we'll discuss the X-ray. Options given were inverted papilloma, rhinophyma, osteoma, and Ringer's tumor. Right? And what is this X-ray showing? So first of all, this is a lateral X-ray of the skull, and we see that this is our frontal sinus. This is my frontal sinus. And within this frontal sinus, I see a very rounded radio-opaque density. So this is the lesion within the frontal sinus. So what becomes the answer? Frontal sinus lesion, benign looking lesion. Why benign looking? Because the overlying cortex is not eroded, it is not expanded, it is just lying inside the frontal sinus. So it is benign, it is within the sinus, and it is sclerotic. So what is the answer? Benign sclerotic tumor of the frontal sinus is osteoma. The answer here is osteoma. Now, what is an inverted papilloma? What is a Ringer's tumor? And what is a rhinophyma? Now, inverted papilloma and Ringer's tumor are synonymous, right? And they occur in the maxillary sinus, right? Now, what is the sign that we see in inverted papilloma? The name of the sign is cerebriform appearance. So inverted papilloma is a tumor of the maxillary sinus. No, Ashish, the answer is not rhinophyma. Rhinophyma is what? It is just a nodular thickening of the nose. This is how a rhinophyma looks like. Okay, Ashish, this is a rhinophyma. We see that there is abnormal nodular growth over the skin of the nose. This you read in dermatology. Okay, this is not seen in radiology questions. This is how a inverted papilloma looks like. What is the name of the sign? Cerebriform appearance. Basically, this inverted papilloma has various infoldings on histopathology. which gives an appearance of sulci and gyri of the brain on MRI. So this is a tumor of the maxillary sinus, and this is my inverted papilloma, also known as Ringer's tumor. Inverted papilloma. Right? Now this is how my osteomas look like. Osteomas are, what are osteomas? They are benign sclerotic bone tumors, and their typical location are in the face, or I can write it as craniofacial skeleton. Craniofacial skeleton osteomas. Right? So this is an osteoma you see in the orbit. This is also a large osteoma in the orbit. So they per se don't cause itself a symptom, but they cause compressive symptoms because they compress on the adjacent structures and the nerves. So in the orbit, they can displace the eyeball and can have difficulty in eye movement. So diplopia can happen, or they can compress a nerve and cause neuropathies. Right? So these are osteomas occur in craniofacial skeleton. They are benign. They are sclerotic. Now, most common location of an osteoma is frontal sinus, and that was given in the question. This is the frontal sinus, and within it you see a sclerotic bone tumor. Yes, Ashish, you are right. Rhinophyma is called as cauliflower nose. Now, a word about osteomas. That what is the association of an osteoma? It is associated with one of the syndromes known as Garden syndrome. Now, Garden syndrome में क्या क्या आता है? Osteomas आते हैं, colonic polyps and fibromatosis. So this is just a theoretical concept. So how do you remember such theoretical concepts? Okay, because question आ सकता है कभी, let's say one liner आ गया, हमें याद नहीं था, question गलत हो गया, तो इसको ना अभी याद रखने का कोई फायदा नहीं है. What I used to do, that all the triads, all the scoring systems, all the classification systems की name, I used to write in a separate notebook. एक छोटी कॉपी बोलते थे हम ना, आजकल सब लोग को पता है छोटी कॉपी क्या होता है. उसमें मेरे अलग अलग सेक्शन थे. तो ये ट्रायड का सेक्शन है, ये क्लासिफिकेशन स्कोर का सेक्शन है, ये स्कोरिंग सिस्टम्स का सेक्शन है. तो उसमें ही मैं सब कुछ लिख लेता था. एंड आई मेड श्योर कि एक दिन पहले बस उसको रीड करके चले जाओ, सो दैट माई मेंटल स्पेस इज नॉट ऑक्यूपाइड विथ थ्योरेटिकल फैक्ट्स. आपको मेंटल स्पेस में अपने कंसेप्ट याद रखने हैं. ठीक है, थ्योरेटिकल रट्टे वाली चीज है, तो एक दिन पहले पढ़ के भी नेक्स्ट डे उल्टी मार के आप आ सकते हो. लाइफ में कोई यूज नहीं होने वाला है इस नॉलेज का. कंसेप्ट अपने दिमाग में रखो. थ्योरेटिकल रट्टे वाली चीज है, राइट इट इन अ स्मॉल कॉपी, जस्ट रीड वन डे बिफोर द एग्जाम एंड वॉमिट आउट. दैट्स इट. नाउ लेट्स कम टू द other sclerotic bone tumors. So one of the sclerotic bone tumors we read was osteomas, and other sclerotic bone tumors are osteoid osteoma. ठीक है, osteoid osteoma. Now how does osteoid osteoma present? So it presents with intense pain. ठीक है, intense pain specifically night में होता है, not relieved by aspirin. Now osteoid osteoma, tell me in the comment section what is the location. Epi, meta or dia? Tell me in the comment section what is the location of the osteoid osteoma. So the location of osteoid osteoma is in the diaphysis, right? And this is how an osteoid osteoma looks like. So you have a small radiolucent center. This is what is my nidus, and this secretes my prostaglandins, which causes intense pain. And surrounding this, we have a lot of sclerosis. Right, so what will be the treatment of an osteoid osteoma? With the help of an RF ablation, radio frequency ablation, we put in a probe inside this osteoid osteoma and burn it. Right, and burn it. So this osteoid osteoma gets burned and the pain relieves. And that is the whole problem of the patient. The problem of the patient is not a deformity, it is just intense pain. You burn the nidus with the help of radiofrequency ablation, and the patient is symptom free, and that is the treatment of choice. Now, the next sclerotic bone tumor, benign sclerotic bone tumors पढ़ रहे हैं हम, is my osteochondroma. Right? हम next पढ़ रहे हैं osteochondroma, also known as एग्जॉस्टोसिस, एग्जॉस्टोसिस। ठीक है, तो ऑस्टियोकॉन्ड्रोमा कैसा दिखता है? पहली बात, फर्स्ट ऑफ ऑल विल रीड अबाउट लोकेशन। ठीक है, लोकेशन होती है इसकी मेटाफाइसिस। ठीक है, एज ग्रुप क्या होती है? यूजली चिल्ड्रन एंड यंग एडल्ट्स। ठीक है, now a specific pointer about osteochondroma that you have to remember that it is exactly not a neoplasm. Okay, it is abnormal growth of my normal growth plate. So normal growth plate was growing like this craniocaudally, but a part of the growth plate starts growing eccentrically. That's why its name is exostosis. So since it's a part of my normal bone, what will it have? It will have cortical continuity and also medullary continuity. Very, very important pointer that always and always an osteochondroma has cortical continuity and medullary continuity. Right? And second most important point, it has a cartilaginous cap at its top. This is my cartilaginous cap. Okay. Now all these are features favoring an osteochondroma. Now another very, very important point for an osteochondroma is that it grows away from the joint. This also we know, grows away from joint. इस तरफ joint था मेरा, ट्यूमर उल्टा ग्रो कर रहा है. So what are the features of malignant transformation in exostosis or osteochondroma? First of all, what kind of malignancy does it transform into? So either a low grade chondrosarcoma or an osteosarcoma. Either a low grade chondrosarcoma or an osteosarcoma. Chondrosarcomas are much more common than osteosarcoma in osteochondromas. And signs of malignant transformation are cartilage cap thickness. बताओ कितना से ज्यादा? मोर देन 1.5 to 2 सेंटीमीटर. कभी कभी एग्जाम में 2 सेंटीमीटर कट ऑफ दिया होता है, कभी कभी 1.5 दिया होता है, दोनों सही है. सेकेंड इंपॉर्टेंट इज ग्रोथ ऑफ दिस osteochondroma after puberty. Why? Because we read that osteochondroma is nothing but abnormal growth plate of my normal growth plate. Growth plate तो stops growing after puberty. So if you see a tumor which is growing in size even after puberty, then you suspect a malignant transformation. And third is persistent pain. Persistent pain not relieved by medications. ठीक है. Now investigation of choice for malignant transformation. पहला पॉइंट हमने पढ़ा था cartilaginous cap thickness more than 1.5 centimeter. Which is the investigation to see the cartilaginous cap? It is my MRI. So investigation of choice for malignant transformation is MRI. अगर कोई पूछा कि गोल्ड स्टैंडर्ड क्या है, गोल्ड स्टैंडर्ड क्या है फॉर malignant transformation? Tell me in the comment section what will be the gold standard to see the malignant transformation in an osteochondroma. Now, whenever we talk about a bone tumor, always and always this is the dictum. Gold standard for diagnosis of a bone tumor is always and always a biopsy. It is my biopsy or histopathological examination. Okay. Now, let's come to the next question. So, a 2-year-old child presents to the ED with respiratory distress and choking. The mother gives the history that the child was playing with coins. His x-rays shown below. What is the location of the foreign body? Okay, very, very important question asked multiple times in the exam. So if you see, this is the frontal x-ray, no doubt about this. This is the frontal x-ray of the neck and the chest. So what do you see? You see a foreign body in the upper trachea. And on the frontal x-ray, this is in the shape of a slit. Right? So tell me, what is the location? What have you guys marked? क्या मार्क किया बताओ? कहां पर है? Now, अगर फ्रंटल एक्सरे पे स्लिट लाइक है तो फॉरेन बॉडी एयरवे में है. Why? Because our vocal cords are also slit like And so if any foreign body is to pass through our vocal cords, it has to be in the same orientation. तो अगर frontal X-ray पर slit like foreign body है, especially coin अगर slit like है, then it is in the airway. And upper airway में larynx है, तो आंसर यहाँ पर larynx हो गया. ठीक है. अगर यही ब्रोंकस में होता तो कहाँ पर होती हमारी फॉरेन बॉडी? इधर होती, अगर ये ब्रोंकस में होती. तो एक बार फटाफट देख लेते हैं कि हाउ डज फॉरेन बॉडी लुक्स लाइक ऑन एयरवे वर्सेस फूड पाइप वर्सेस इसोफेगस. ठीक है. तो अगर लैटरल एक्सरे में स्लिट लाइक लग रही है फॉरेन बॉडी, देन इट इज इन द इसोफेगस. तो हियर it is in the esophagus. And another sign that you can see that it is not in the trachea is that you can see the trachea separately on the anterior side. ये airway का column दिख रहा है, this is my trachea, and उसके पीछे foreign body है, so this is in the esophagus. And likely esophageal foreign body on an AP radiograph will be circular, right? Now similarly अगर bronchus में होगी foreign body, this is the location of foreign body in the bronchus. राइट. नाउ फॉरेन बॉडी, दूसरा आपको ये भी चल जाएगा पता, ये एयरवे है एंड लैटरल एक्सरे पर अगर स्लिट लाइक है अगेन फॉरेन बॉडी, तो हमारे इसोफेगस में है. नाउ अगेन दिस इज अनदर एग्जांपल ऑफ अ फॉरेन बॉडी, अ हेयर पिन जो बच्चे ने स्वैलो कर लिया, दिस वाज इन द ब्रोंकस, दिस इज इन द ब्रोंकस, दिस इज द शेप ऑफ द ब्रोंकस. सो अगेन दिस फॉरेन बॉडी इज इन द ब्रोंकस. नाउ इस बार INICET में क्वेश्चन आया था कि एक फॉरेन बॉडी तो दे रखी थी एंड पीपल ऑल्सो न्यू दैट इट इज इन द इसोफेगस, बट इट वॉज आस्क्ड वेदर इट इज अ कॉइन और अ बैटरी. इट वॉज आस्क्ड व्हाट इज द लाइकली फॉरेन बॉडी. सो देयर आर फ्यू पॉइंटर्स टू डिफरेंशिएट अ बटन बैटरी फ्रॉम अ कॉइन. तो फर्स्ट ऑफ ऑल अ बटन बैटरी, इफ यू लुक एट बटन बैटरी, क्या होती है बटन बैटरी? जो वॉचेस में डलती है, लेकिन बच्चे आराम से उसको खा लेते हैं. तो बटन बैटरी has these beveled edges. ठीक है, ये बटन बैटरी में होते हैं. इसको आप एज साइन भी बोल सकते हो, ठीक है, बट बेवेल्ड एजेस याद रखो. दूसरा जो बटन बैटरी होता है ना, बिकॉज ऑफ दिस बेवेल्ड एजेस इट हैज अ हेलो, इट हैज अ सर्कुलर इनर हेलो अराउंड इट. तो टू इंपॉर्टेंट साइंस, हेलो साइन and beveled edges. These tell you that it is a button battery and not a coin, right? Now let's move on to the next question. A 20 years old male is presented with chief complaints of frequent epistaxis with a nasal blockage. Okay, so epistaxis and nasal blockage से बात कर रहे हैं. Examination polypoidal mass है, growing from the nose to the nasopharynx, so it is growing posteriorly, completely occupying the posterior concha. You suspect an angiofibroma. ठीक है, young patient, recurrent epistaxis, nasal blockage, JNA is my first differential. What is the investigation of choice for a JNA? Now, investigation of choice for a JNA is my CECT. Investigation of choice is my CECT. Now, how does a JNA looks like? So you see that so normally a JNA, if we talk about a JNA, juvenile nasopharyngeal angiofibroma, juvenile angiofibroma, so it is a vascular tumor. What you have to remember that it is a vascular tumor. ठीक है, एंड इट साइट ऑफ ओरिजिन अगर कोई पूछे, साइट ऑफ ओरिजिन, इट इज माई स्फीनोपैलेटाइन फोरामेन. And from the sphenopalatine foramen, you know, it grows both into the nose or the nasal cavity and also posteriorly into the pterygopalatine fossa. Right? Now tell me in the comment section, what is the sign that you see on a JNA? साइन एक्सरे पे साइन मिलता है हमें, सीटी स्कैन पे भी साइन मिलता है एक जेएनए में. टेल मी, एंटीरियर बोइंग ऑफ द पोस्टीरियर वॉल ऑफ द मैक्सिलरी साइनस, व्हाट इज इट नोन एज? The name of the sign is Hallman-Miller sign. Hallman-Miller sign. This is anterior bowing of the posterior wall of the nasal cavity of the maxillary sinus. Sorry. Now, treatment obviously for a JNA is surgery. But before surgery, what do we want to know? That what is the extent of this JNA? So for staging, just remember the name of the staging. Staging name is 𝐒𝐂𝐄𝐝 staging. 𝐒𝐂𝐄𝐝 staging. It tells whether the JNA is limited to the nose, pterygopalatine fossa, or it has extended into the cranial cavity, because then the management would change. Now, since it's a very vascular tumor, prior to your surgery, the surgeons frequently send it to radiologists for pre-operative embolization. So remember, a JNA is one tumor that before surgery, before you're planning a surgery to devascularize this tumor, you can do a pre-operative embolization. Okay. Treatment is surgery, but before that you do a pre-op embolization. Now, other tumors of the neck will just go through. So this is, so you see that this is a tumor which is splaying the carotid vessels. Okay, this is within the carotid sheath. It is splaying the carotid vessels. Here also you can see that it is a very vascular tumor. It is displacing the external carotid and the internal carotid. It is splaying it. So this is my carotid body tumor. Carotid body tumor. How do you identify it? It causes splaying of the ICA and ECA because it arises from the carotid body, which is present at the bifurcation, right? So what is the diagnosis? It is CBT. And just remember the classification system. What is the name of the classification system for carotid body tumor? It is my Chamblin's classification. Chamblin's classification. So this is a brief capsule about carotid body tumor. Now, one more important finding, important sign that you see in a carotid body tumor. So since it is a paraganglioma, a type of paraganglioma, so it has a lot of flow voids within. You see that this is a diagnostic angiogram. You see splaying of the internal and the external carotid arteries and a lot of tortuous vessels. Because this lot of tortuous vessels, this gives a salt and pepper appearance. So name of the sign is salt and pepper appearance. And another sign is on DSA where you see splaying of ICA and ECA. This is known as my Liar's sign. Right? Now, next tumor of the head and neck that we'll quickly go through is my glomus tympanicum or glomus jugulare paraganglioma. Right? So, if it is involving both the middle ear as well as the jugular foramen, then it is glomus jugulare. Or if it is just involving the middle ear, then it is glomus tympanicum. Right? So it is present within the ear and at the jugular foramen So what is the diagnosis? The diagnosis is glomus jugulare. And what is the classification system that we use for glomus jugulare tumor? It is my Fish classification. Fish classification. So 3 tumors, 3 classification system we read. For JNA, 𝐒𝐂𝐝𝐿, for carotid body tumor, Chamblin's, and for glomus jugulare, Fish classification system. Right? On the CT scan, what you'll see, since it is involving my jugular foramen, then the jugular spine will get eroded. Okay, this is how you identify that this is located in the jugular fossa. Now, next question we'll move on to. That a 47-year-old woman comes in with shortness of breath, chest pain and cough. She has a history of living in rural areas with exposure to sheep. The chest image is shown below. Given the image, what is the likely diagnosis? So both the CT scan and the X-ray are given. So on the X-ray, you see a thin-walled cavity. You see a thin walled cavity, right, with some contents at its lower end, right? And on the corresponding CT, you see again a thin walled cavity. And in the question you have seen that there is exposure to sheep. So there is exposure to sheep. So what is the likely diagnosis here? It is my lung hydatid cyst. Okay. Now, how does a lung abscess looks like? Pulmonary TB looks like. Pulmonary embolism, I think, is not the option. It's not the consideration at all. So I don't think anybody would have marked pulmonary embolism. What have you guys marked? Tell me in the comment section. Answer is lung hydatid. Now, some of you might ask, why is it not a lung abscess? So lung abscess, if you see a picture of lung abscess, it will have a thick wall. It will have a thick wall surrounding it because it is formed by a necrotic cavity. And also you will see these air fluid levels. So in a lung abscess, you will see thick irregular walls and you will see air fluid levels and surrounding lung consolidation because it is an underlying infective process. Right. Now, how does a pulmonary TB looks like? Pulmonary tuberculosis can have various forms. So if there are multiple nodules spread throughout the lungs, this is my miliary TB. Right. Most commonly in a reactivation form or a secondary reactivation, secondary TB, we get an upper lobe predominance cavitary lesion with surrounding consolidation. Right. So this is my cavity with surrounding consolidation and fibrosis. This is my secondary TB or reactivation of TB. Now another form which can happen in a sequelae of TB is a ball-shaped lesion within a previously formed TB cavity. What is this known as? This is my aspergilloma. Aspergilloma. And aspergilloma gives what sign? It gives Monod's sign, also known as a crescent, air crescent sign. Now another manifestation of aspergilloma. So tell me, how does aspergilloma presents like? So it presents with massive hemoptysis. Okay, because it erodes the wall of this cavity and causes massive hemoptysis, aspergilloma. Another manifestation of aspergilloma that we see in previously formed TB cases and as a reaction to hypersensitivity to aspergillus fungus is my ABPA or allergic bronchopulmonary aspergillosis. Allergic bronchopulmonary aspergillosis. Now, what is the sign that you see in ABPA? Name of the sign? Finger in glove appearance. Finger in glove appearance. Why? Because upper lobe bronchiectasis filled with mucus gives finger in glove appearance. What is specific sign of aspergillosis? It is high attenuation mucus on non-contrast CT. High attenuation mucus because this fungal elements of aspergillus are bright on CT. That is why the mucus that is impacted within the bronchiectasis appears hyperdense, known as high attenuation mucus. This was the brief capsule of tuberculosis. Now let's move on to the next question. 52-year-old male with history of open appendectomy presents with symptoms of abdominal distension and vomiting. What finding would you expect to observe on the X-ray abdomen? So options are dilated colonic loops, ileal loops, jejunal loops, and stomach. What have you guys marked? Let's rule out. Okay? Let's rule out few questions, few options, because that is how you attempt any question in the exam. You first rule out the options. So stomach, it cannot be. It will either be a small or a large bowel. Okay, large bowel it cannot be. Why? Because there are complete septa. So these are not hostration, but these are valvular conjunctivitis. So we have ruled out dilated colonic loops. Now, ileum versus jejunum, how will we figure out? So mostly based on the location, right? So if it's in the upper abdomen, I'm more likely to mark them as jejunum. If it's in the lower abdomen, I'll preferably mark them as ileum. So they are in the upper abdomen, I'll mark them as dilated jejunal loop. Okay, easy question. Let's move on to the let's move on. How to differentiate between small bowel and large bowel obstruction. So first of all, tell me what is the investigation of choice for intestinal obstruction. So investigation of choice is always a contrast enhanced CT. Now, in a contrast enhanced CT, tell me whether you'll give an oral contrast or not. Oral contrast दोगे आप कि नहीं? So intestinal obstruction में remember oral contrast is contraindicated. Why? Because intestines वैसे ही आगे नहीं भेज रही, कुछ obstruction है, आप ऊपर से कुछ पिला दो पेशेंट्स को, तो aspiration के chances बहुत ज़्यादा हैं. There is risk of aspiration in intestinal obstruction. That is why oral contrast is contraindicated. And you know, whenever intestines are obstructed, the fluid in the intestines act as a natural contrast. You don't need to give extra contrast to see the level of obstruction, right? So investigation of choice is CCT, oral contrast is contraindicated. Now how do you differentiate between a small and a large bowel? We've already read it. Small bowel will have complete septations known as valvular conjunctivitis, whereas large bowel will have incomplete septations known as Hofstra. Second, small bowel will be in the center of the abdomen and large bowel will be in the periphery of the abdomen. Right? So these are the important differences between a small and a large bowel obstruction. Now since we are on the topic of obstruction, we'll complete midgut volvulus here only. So first of all, midgut volvulus occurs in neonates. And it presents with bilious vomiting. And inability to feed. And this is actually an emergency. This is a neonatal emergency which you have to diagnose. So first of all, what happens that midgut volvulus occurs in patients with malrotation of gut. So in patients with malrotation, you have a short insertion of mesentery and a large mesentery hanging the intestines. So it is likely to undergo torsion. That is what is midgut volvulus. Now whenever this torsion happens, because there is an underlying malrotation, the duodenum does not cross the midline. So what are the signs of midgut volvulus? Signs are duodenum or my DJ flexure not crossing midline. Right, you see that the duodenum has not crossed midline. The DJ flexure is continuing into the jejunum on the right side only. So this is one finding. Second, on CT and on ultrasound, you will see a whirlpool sign. Whirlpool sign is nothing but twisting of the mesentery, giving a whirlpool-like appearance. And on an ultrasound, you will see that the SMA and SMV relations are reversed. SMA and SMV relationship is reversed. Now, what is the investigation of choice for midgut volvulus? Is my upper GI contrast study. And treatment is surgery. So this is a brief overview of my midgut volvulus. Investigation of choice is my upper GI contrast study. Now a word about intussusception that also causes obstruction specifically in children and infants. So intussusception is nothing but telescoping of one bowel into the other. Most common site is my iliocolic followed by colocolic intussusception. Now clinical features are inability to feed, inconsolable crying, but what you get in the question is this buzzword of red currant jelly stools. basically mucus filled stools associated with blood. Investigation of choice for intussusception is my ultrasound, and gold standard is barium enema. Now what are the signs? So there is telescoping of one bowel into the other. So this gives a target sign, also known as a donut sign. And if you put it in another plane, a sagittal plane, you'll get a pseudo kidney sign. So these signs were on ultrasound. And what are the signs on barium? You see this claw sign or a coiled spring sign. Now treatment for intussusception, if it is an ileocholic or colocolic intussusception and it is not perforated, then you can attempt a barium reduction or a pneumatic reduction. Basically, what do we do in barium reduction? We instill barium solution through the patient's rectum and try to reduce this intussusception. Now nowadays barium is not used because it stays in the intestine for a longer time. We instead instill air into the large bowel retrogradely. This is known as pneumatic reduction, instilling air through the rectum into the bowel so as to reduce this intussusception. This is only and only done if it is non-perforated system. Okay, very, very important for you to know. Barium reduction or pneumatic reduction is contraindicated in cases of perforation. And it is to be done in ileocholic or a colocolic intussusception. For small bowel into, you have to do a surgery. Or if it is a perforated ileocholic or colocolic intussusception, again you will have to do a surgery. So this is a brief capsule for intussusception. Now let's move on to the next question. A 70-year-old male patient presented to the urology outpatient department with complaints of poor urine stream, straining during maturation, and further workup, he was diagnosed to have locally advanced prostate cancer. A decision was taken to start the patient on radiotherapy in the form of brachytherapy. And which of the following statements is not correct? So incorrect statement we have to identify regarding this mode of radiation therapy. So we are talking about brachytherapy as the radiation mode, and we have to find the incorrect statement. So first statement, it involves placement of radiation sources inside the patient's body. Yes. It is further categorized into interstitial, intracavitary and mold. Yes. In locally advanced prostate cancers, the radioactive source implant is embedded within the glandular parenchyma. Yes. The most common radioisotope used for brachytherapy of prostate cancer is iodine 127. No, it is iodine 125. Is iodine 125. So this is my incorrect statement and the correct answer to this question. Now the next question, a 4th year MBBS student was posted in the Department of Radiation Oncology for a selective rotation. Okay. Now based on Bragg-Peak effect, the resident on call chose to proceed with radiotherapy while treating a patient with 𝐒𝐈𝐀. Okay, typical brain tumor that we treat with one type of radiotherapy which causes Bragg-Peak effect. Now he is questioned the medical student what particle will have the strongest Bragg-Peak effect. So tell me in the comment section which particle shows Bragg-Peak effect. It is my protons. Proton beam shows Bragg-Peak effect. Now this is my Bragg-Peak effect which has been demonstrated. And what is Bragg-Peak effect? Actually, if you see normal radiotherapy, so first of all tell me what is the most common source of radiotherapy, which is the most common agent that we use in radiotherapy. These are X-rays. Normally X-rays are used for radiotherapy. high energy X-rays as compared to low energy X-rays in diagnostic. Now, X-rays show normally maximum radiation dose at the surface, and then the radiation dose gradually drops as the radiations enter the body. Why? Because their energy is directly proportional to their velocity, right? Whereas for protons, the energy deposited in the tissue is inversely proportional to their velocity. So as the protons enter inside the body, their velocity decrease, and at a particular distance from the surface of the body, the radiation deposited is maximum. This is my Bragg peak effect. Why? Because for protons, the energy deposited is inversely proportional to the velocity. Now, why is it so useful? Because for deep-seated tumors of the brain, we don't want to destroy the surrounding structures. So that is why we use proton beams for treatment of deep-seated tumors like 𝐒𝐈𝐀𝐃, okay, which show Bragg peak effect. So Bragg peak effect is shown by proton beams. Now let's just revise radiotherapy briefly. So 3 modes of radiotherapy: teletherapy or radiation from a distance. So for teletherapy, which is the most common agent that we use cobalt-60, right? Brachytherapy is radiotherapy from close. So it can either be interstitial, in which you embed some implants in the tumor tissue. For example, in prostate we use this, in breast we use this, breast cancer. What is intracavitary? That for hollow organs like cervical cancer, we put in some probes, we load them with radioactive material and radioactive substance, and they emit radiation. So for CA cervix, we use intracavitary brachytherapy. And finally, for superficial cancers, for example, eyelid cancers or nasal cancers, basal cell carcinoma of the nose, we give mold therapy for superficial cancers. Right? So this is an example of my intracavitary brachytherapy for CA cervix. We have inserted tandems inside the vagina, and there is an applicator which is used to treat the cervical cancer. Now, systemic radiotherapy is that if you give any radioactive substance either orally or through IV injection, then it is known as systemic radiotherapy. For example, radioactive iodine uptake that we use in CA thyroid, right? So iodine 131 is my agent which is used in systemic radiotherapy for CA thyroid. Now these are this is how an interstitial brachytherapy look like. This is for breast, this is for prostate. This is my mold brachytherapy. This is my mold brachytherapy, right? So these are all types of brachytherapies. Now what are the agents of teletherapy? So first we have read gamma rays. Gamma rays is secreted by cobalt-60, which have a half-life of 5.2 years. If take a snapshot of this slide, most of the questions for your agents of teletherapy will be solved from here. So first agent of teletherapy is gamma rays, which most commonly uses cobalt-60 or cesium-137. Then we have X-rays, which are the most common source for radiotherapy. Now they can have different energies, and accordingly they are named orthovoltage, orthovoltage X-rays, super X-rays, super voltage X-rays, or mega voltage X-rays. Then we have electron beams, which are used to treat superficial surgeries, and also electron beams are a method of radiation therapy for intraoperative radiation. Finally, we have proton beams. We've already read a question that proton beams show Bragg peak effect, and they are produced by cyclotrons, which are particle accelerator. Now, because of these Bragg peak effect, proton beams are used to treat deep-seated tissues, deep-seated tumors of the brain, like 𝐒𝐈𝐴-chordoma. So this is the property of proton beams. 𝐒𝐈𝐴-chordoma is a central tumor. We use proton beam to treat it. Now finally, we have stereotactic radiotherapy. Stereotactic radiotherapy is a type of teletherapy only, in which multiple radiations are focused on a particular area. तो कहाँ use करते हैं बताओ stereotactic radiation therapy? We use it in brain, we use it for lung cancers, for liver cancers. So for brain, we use gamma knife. Okay, as the name suggests, gamma knife uses gamma rays, and they are produced by cobalt-60. एंड गामा नाइफ जब भी हम यूज करते हैं हम एक स्पेशल फ्रेम का यूज करते हैं. व्हाट इज द नेम ऑफ दैट फ्रेम? लेक्सेल फ्रेम, राइट. एंड अगर हमें बॉडी के ट्यूमर्स को एब्लेट करना है यूजिंग रेडिएशन, देन वी यूज फाइबर नाइफ. फाइबर नाइफ यूजेस एक्स-रेज, right? And here we do not use any Lexell frame. Now, what are the tumors of the brain which can be treated by gamma knife? So first is vestibular schwannoma, trigeminal neuralgia. AVM, brain AVMs can also be treated by gamma knife. Then pituitary microadenoma also, and meningioma. These are the tumors treated by gamma knife. Now this is how Lexell frame looks like, right? This is my Lexell frame. Right, so this basically has a lot of coordinates and it keeps the head still during radiation, during gamma knife. And these are the various gamma rays probes which burn a particular area inside the brain. This is how my cyber knife looks like. So cyber knife has a robotic arm. This is the robotic arm. And this, what is this first image? This is a normal image of my cobalt scanner, cobalt-60 machine, teletherapy machine. Now a word about fractionated radiotherapy, because fractionated radiotherapy पे क्वेश्चन अभी रिसेंटली FMG में आया है. FMG में आया तो नीट पीजी में 100% आ सकता है. तो फ्रैक्शनेशन मतलब कि टोटल बड़ी डोज को हम स्मॉल पार्ट्स में डिवाइड करके दे रहे हैं. ठीक है, सो द टोटल डोज इज डिवाइडेड इनटू मल्टीपल स्मॉल डोजेस एंड इट इज गिवन 5 days अ वीक. सो वीकेंड्स ऑफ मिलते हैं यहाँ पर भी पेशेंट को. एंड व्हाई इज इट डन? बिकॉज अ सिंगल हाई डोज विल हैव अ लॉट ऑफ साइड इफेक्ट्स, and because it will give both the normal and the abnormal cells. With the help of fractionation, the normal cells can get repaired, they can get the time to repair, whereas in cancer cells we know that DNA repair mechanisms are absent or defective, so the cancer cells will not be able to repair themselves, whereas the normal cells will get the time to repair on the weekends. Okay, so how does a normal fractionation happens? In a normal fractionation हम एक fraction में 1.8 to 2.2 gray radiation देते हैं, and these fractions are given only once per day and given 5 days a week. So if this is my week, it will be given on Monday, Tuesday, Wednesday, Thursday, Friday. Okay, 5 days a week I'll give between 1.8 to 2.2 gray once per day, and weekends I'll give off. Now there are few modifications of this fractionation. So what is hyperfractionation? What is hypofractionation? So in hyperfractionation, I'm again giving it 5 times a day only, 5 times a week only, but I'm giving it both morning and evening, both morning and evening. So per day, I'm giving 2 fractions, per fraction dose will be less, right? So around 1.5, 1.1 gray per fraction, I'm giving the dose. So per day, I'm giving 2.2 only, but I'm dividing it into morning, evening, morning, evening. This is my hyperfractionation, right? Now, what is hypofractionation? That per fraction dose, I'm increasing. Per fraction dose, I'm increasing a little bit. So what advantage it will have? The total duration will reduce. Total duration will reduce. This is hypofractionation. This is hyperfractionation. Now, finally, we'll read about the half-life of few radioisotopes, and with that, we'll complete our radiotherapy session for this TND. एंड रेडियोथेरेपी बस इतना ही पढ़ना, ठीक है. इसमें सारा रेडियोथेरेपी ऑफ ट्राई टू कवर. इसके बाहर रेडियोथेरेपी से नहीं आएंगे कोई क्वेश्चंस. ज़्यादा टाइम मत वेस्ट करना रेडियोथेरेपी पे. I've tried to incorporate everything that is important from radiotherapy point of view into today's TND. So half-life of radioisotopes, again, just take a picture of this slide, keep it in your phone ready and just read it one day before the exam. तो आयोडीन के मोस्ट कॉमनली पूछे जाते हैं. आयोडीन 123, हाफ लाइफ इज 13 आवर्स, 125 60 डेज, 131 इज 8 डेज. ठीक है, कैसे याद करना है? जो भी छोटे वाले नंबर के हैं रेडियो आइसोटोप्स, दे आर यूज्ड इन डायग्नोस्टिक्स. तो डायग्नोस्टिक लाइक थायराइड स्कैन. तो थायराइड स्कैन जब भी डायग्नोस्टिक में कोई रेडियो आइसोटोप यूज करेंगे उसका हाइफ लाइफ कम होगा, बिकॉज वी वांट द रेडियो आइसोटोप टू वॉश फ्रॉम द बॉडी, राइट. वेरास अगर हम किसी रेडियो आइसोटोप को रेडियोथेरेपी के लिए यूज कर रहे हैं, वी वुड वांट अ लॉन्गर हाफ लाइफ. ठीक है, बिकॉज वी वांट इट टू स्टे इनसाइड द पेशेंट्स बॉडी एंड गिव रेडिएशन, किल द सेल्स. So 125 and 131 are used in radiation therapy. 123 is used in thyroid scans. ठीक है, तो 123 का कैसे याद रखेंगे? 13.2 hours. 13.2 hours. 125 का 12 into 5 60 days and 131 का 3 को 8 बना दो आप, 8 days. ठीक है. 131 I use it in radioactive iodine ablation. 125 I use it in brachytherapy for prostate cancer. ठीक है. Now technetium 99M again a most common radioisotope used in all gamma imaging. उसकी हाफ लाइफ पूछी जाती है 6 hours. FDG में 18F जो हम रेडियो आइसोटोप यूज करते हैं उसका हाफ लाइफ इज 110 minutes. Then cobalt 60, cesium 137, iridium 192 and radium 226. इसके इतने इंपॉर्टेंट नहीं है. You can also skip learning these. Now let's move on to the next question. Which of the conditions has the X-ray characteristics that resemble the one that is shown below in the image? Basically पूछा है कि diagnosis क्या है. तो टेल मी, नी एक्सरे दे रखा है आपको, स्क्लेरोसिस दे रखी है एपिफाइसिस के चारों तरफ. व्हाट इज द आंसर? आंसर हियर इज कर्वी. ठीक है. नाउ हमने एज अ डिक्टम बना लिया था जब मस्कुलोस्केलेटल इमेज कर रहे थे कि रिस्ट का एक्सरे दे रखा होगा, हैंड एक्सरे दे रखा होगा एंड बच्चा दे रखा होगा, तो आई थिंक ऑफ रिकेट्स. नी में आई थिंक ऑफ स्कर्वी. बट एक बार देख लिया तो उसके साइंस भी पढ़ लो. तो स्कर्वी के साइंस क्या क्या होते हैं? हम स्कर्वी के साइंस पढ़ रहे हैं. सबसे पहले यू हैव दीज पेंसिल थिन कॉर्टेक्स. वी आर रीडिंग साइंस ऑफ स्कर्वी. फर्स्ट इज पेंसिल थिन कॉर्टेक्स. उसके अलावा उसके बाद हमारे टिपिकल साइंस आते हैं. तो एपिफाइसिस के चारों तरफ रिंग एपिफाइसिस इज माय विंगबर्गर्स रिंग साइन. देन जो मेटाफाइसिस है उसमें स्क्लेरोसिस जो हो जाता है, दैट इज माय वाइट लाइन ऑफ फ्रैंकल. सो दिस इज नथिंग बट प्रोविजनल जोन ऑफ कैल्सिफिकेशन. देन उसके नीचे एक रेडियोल्यूसेंट जोन मिलता है, ट्रमर फील्ड. Radiolucent zone, and finally I have a Pelkin spur. Pelkin spur, right? Now इसके अलावा sometimes you can get subperiosteal hemorrhages also. Subperiosteal hemorrhages. These are the subperiosteal hemorrhages, and you can see that the periosteum is elevated. It is lifted up because of these subperiosteal hemorrhages. These are seen in scurvy. Whereas, tell me, what are the signs of rickets? So in rickets, we know that hand X-ray will be given, and the changes will be there in the wrist. Right? So you see Widening of growth plate. This is my growth plate which has widened. I have widening of growth plate. Then there is this cupping of metaphysis. There is fraying, and then there is spaying of metaphysis, right? And these changes you can see both in the knee as well as in the hand x-ray. So this is the x-ray of the knee. Again, you can see cupping and fraying as well as spaying, right? Another type of deformity that is asked with respect to rickets is this wind-swept deformity. So this is wind-swept deformity. Whereas what is this x-ray showing? These are showing nothing but signs of healed rickets. So again, you see these parallel white lines. These are metaphyseal lines which tell you that this is a healed rickets. Basically, there is some ossification which has started to happen, and these appear as these metaphyseal bands. These are known as metaphyseal bands, sign of healed rickets. Right, now we move on to the next question. A 30-year-old patient has a history of car accident 2 years ago and is experiencing pain and swelling in the same area. Is X-ray shown in the below, which is the most likely diagnosis? ठीक है, so accident हुआ था 2 साल पहले and अभी pain and swelling हो रही है. Now what is the X-ray that is given to us? You see that the bone is a little deformed. There is a lot of sclerosis happening and there is this area of abnormality. This is what is known as my sequestrum. Sequestrum is nothing but my sequestered dead bone. Okay, entrapped dead bone is my sequestrum. Now, sequestrum is hallmark of what condition? Chronic osteomyelitis. Now let's rule out other options as well. Ewing sarcoma हो सकता है 30-year-old में? नहीं हो सकता. ऑस्टियोजेनिक सार्कोमा हो सकता है? हाँ, हो तो सकता है. सेकेंडरी ऑस्टियोसार्कोमा होता है एल्डरली में, बट मोस्ट कॉमन एज ऑफ ऑस्टियोसार्कोमा इज बिफोर 20 years of age. तो मल्टीपल माइलोमा हो सकता है 30-year-old में, बट मल्टीपल लिटिक लीजन्स मिलेंगे मल्टीपल माइलोमा में. इसमें तो स्क्लेरोसिस मिल रही है हमें. तो अगेन विद द बैकग्राउंड ऑफ हिस्ट्री, आंसर हियर इज chronic osteomyelitis. Now let's see other types of osteomyelitis. So if you see a type of osteomyelitis in the metaphysis crossing the growth plate, this is my Brodie's abscess. And a type of subacute osteomyelitis occurring in the mandible is my Gary's osteomyelitis. Both of them are types of subacute osteomyelitis. Now what is this MRI showing to you? This is an MRI of the ankle and foot. This is sagittal T2. I'll write it down. This is a sagittal T2 fat sat MRI of foot. And what is this showing you? It is showing you these lesions. Okay. What is this known as? This is known as circle in dot sign seen in diagnosis is Madura foot or actinomycetes, right? So circle and dot sign seen in Madura foot, right? Now in other infections of the MSK region we'll talk about. So this is my tuberculosis. This is my tuberculosis of the knee. And what is the triad that I see in tuberculosis? It is my Phemister's triad. So it has erosions. It has osteopenia. Right? And the third thing I'll tell you in a bit. And what is the TB of the, if you have a TB of the small fingers, this is known as spina ventosa. Or dactylitis. So spina ventosa appears as this radiolucent area in the small fingers associated with this large soft tissue swelling. This is TB of the small fingers. And most commonly what you get in the exam is this TB of the spine, known as my Pott's spine. So remember this hallmark typical image. You will see that this part of the vertebra is damaged, it is eroded, it is lytic, okay, because of the infection of this bone, and the adjacent vertebra are adjacent discs are spared. So remember, Pott's spine spares the intervertebral discs, or even if they are involved in a later stage. First of all, the vertebral body is involved, right? Now let's move on to the next question. So a 25-year-old male injured his right shoulder when he was playing rugby. Currently, he feels pain in his right shoulder and is unable to move. X-ray of the shoulder was done and is given below. What is this lesion depicted? So this is the lesion that we are talking about. This is the lesion that we are talking about. And so if you see a lesion in a dislocated shoulder of an athlete on the posterior superior aspect of the humerus. Posterior superior aspect of the humerus. Where is this lesion located? What is this called? This is known as my Hill-Sachs lesion. Hill-Sachs lesion. And tell me, in what type of shoulder dislocation do you see a Hill-Sachs lesion? Anterior shoulder dislocation. Now someone might ask me, sir, Bankart lesion क्यों नहीं है? So Bankart, remember, happens on the glenoid. Bankart lesion glenoid का lesion है. Humerus पे lesions दो होते हैं, Hill-Sachs या reverse Hill-Sachs. Hill-Sachs lesion होता है posterior superior aspect पे, और reverse Hill-Sachs इसका उल्टा कर दो, anterior inferior aspect of the humerus. ठीक है? Let's quickly see how these structures, how these Hill-Sachs and reverse Hill-Sachs form. So remember, Bankart lesion is nothing but a bony Bankart is avulsion fracture of a part of the glenoid. Okay, this is my Bankart lesion. It is present on the glenoid or scapula. Whereas Hill-Sachs lesion is in the posterior superior aspect of the humerus. Now, why does this happen? That whenever the shoulder is dislocated anteriorly, anterior part of this glenoid will be fractured, and hence you see this bony fragment. And whenever the shoulder comes anteriorly, this impacted bone will hit what part? It will hit the posterior superior aspect of the humerus. That's why you see Hill-Sachs on the posterior superior aspect of the humerus and the glenoid on the anterior aspect of the glenoid cavity. Bankart lesion is on the anterior aspect of the glenoid. Okay, this is with respect to my anterior shoulder dislocation. Whereas for a posterior shoulder dislocation, what sign do I get in a posterior shoulder dislocation? I get a light bulb sign. Right? Dislocated shoulder appears like a light bulb. And what are the signs with respect to Hill-Sachs and Bankart? So you get a reverse Hill-Sachs sign. In cases of posterior dislocation. Right?